Testing, testing, testing. Is that a little bit better? Sweet. Okay, sweet. Okay, I think we're good as long as they're on. Thank you, I appreciate it. Okay. Good to go. Okay. Oh. Oh, I was just gonna maybe fiddle around with the whiteboard, but it's okay. All right, before we get started. What's that? Good to see you. Well, I got it. Good to go? Okay. Good morning, folks. I know that I am standing between you and lunch, so I will try not to make this too painful. My name is Jesse Bohrer Clancy. I am the medical director for, wait, let me back up. I started off as a dive instructor and a bartender after realizing that I did not want to be a research chemist. It sounds cool. It's actually really, really boring doing bench research. I then took an EMT class on a whim, and during the paramedic ride time, I was like, oh no, this is what I want to do. And so got my prereqs done, went to Shemeketa, got my paramedic, worked as a paramedic in the field for almost 5 years in the Woodburn area, and then made the mistake of going to medical school, went to OHSU about that way, hated it, and then went to residency in emergency medicine in Hartford, Connecticut, and absolutely loved it. And then decided to do an EMS fellowship down in New Haven, Connecticut for a year. Loved that as well, and then came back. I am the associate medical director for Washington County, the medical director for Hillsborough Fire, and the medical director for Shemeketa's paramedic program and the satellite paramedic programs in here in Pendleton at Blue Mountain, out in Ontario at Treasure Valley. We're opening up another one in the Columbia Gorge in the Dalles, and then rumor has it there's some folks on the coast that want to talk to us as well. How many of you, either during training or because something happened, have actually been tied to a long backboard? Fantastic. Keep your hand up if you really, really enjoyed it. Oh, come on now. So I started to hate these things during the paramedic program when somebody was like, does anybody want to experience this? Not me being an idiot, raised my hand. I've got another example of me being an idiot when I decided to let somebody tase me. An interesting experience, by the way. And yeah, they strapped me down the backboard, C-collar, head blocks, spider straps, whole 9 yards, drove me around in the parking lot for about 5 minutes and had a scorching headache afterwards. These things suck. And what you'll realize is, one, that I apologize in advance if I use any salty language. But second of all, that they don't work. Okay, they're just not useful devices. So I do not have any financial interests, conflicts of interest to disclose. Nobody's paying me to tell you how much I hate long backboards. All the anatomy images are from Netter's Anatomy 8th edition in case they try to sue me. And then I hate long backboards. Okay. The other thing too is you'll notice that some of the things on the slides will be a different color and it'll be underlined. Those are all hyperlinks. So I'm going to send this presentation out because one of the things I always hated when I was a medic is you bring a patient in the hospital and you either get a nurse or a physician who starts chewing you out. And they're like, well, why did you do this? You shouldn't have, blah, blah, blah. This way you can be like, actually, according to these studies, because in EMS, we really like to go by what's called evidence-based medicine, meaning there's an actual logical scientific reason why we're doing something, as opposed to eminence-based medicine, where some yahoo with an MD or a DO behind their name thinks that they know everything. And there's a good chance that they don't, okay? Half of what they teach you in medical school is wrong. We just don't know which half, okay? And so I want each and every one of you, I know, it feels great, doesn't it? You're like, oh, awesome, I can't wait till I get sick, doc. I want you all to have the information to back up all these arguments, okay? I want you to make your own independent assessments. Don't trust me. I'm an idiot. Ask Val. And so I want you to make sure that you're able to independently assess this for yourselves, okay? So do a little fun with anatomy. So skull right here contains your brain. It's got some skin over it called the scalp. Weighs about 8 pounds, 4 kilograms if we're not doing the freedom fraction thing. The spine, you've got your 7 cervical vertebrae, your 12 thoracic, and then your 5 lumbar. Notice that, okay, these are a little bit smaller and they gradually get bigger as you go down towards your hips. The other thing too is that these cervical ones up here, it's basically like a spring holding an 8-pound bowling ball, rolling around like this. There's not a whole lot to support it. Whereas your thoracic and your lumbar have the rest of your torso to support that, and they're also a lot bigger. So they're less likely to get injured. So if you kind of start off at the top, this is the atlas vertebrae. Atlas holds the skull, allows you to rotate it around or move it this way. And then that rotates around C2, okay, or what we call the axis. And that thing sticking out of the top is the dens, which is Latin for tooth. I don't know. I didn't make it up. But basically it rotates around that. And as you'll notice, you've got all these ligaments there kind of holding everything together, along with all the paraspinous muscles, which aren't on there. About 5% of all the C-spine fractures will actually happen on the atlas. About 40% will happen on the axis. The rest of them are usually around C5 and C6, just based on the way most injuries are and where basically that point of flexion or extension is going to be in the neck. So here, that one is C3, so that's the first normal looking one after the atlas and the axis. But you notice how it's a little bit thinner, okay? So these things are a little bit easier to break. Plus, again, there's nothing else supporting it, and it's holding that bowling ball on. Go down to C4, a little bit thicker. Go down to, you're starting to get into the thoracic ones, okay? So this is T6. Down to L2. they keep getting bigger and thicker because they're supporting more weight, which means they're also a little bit harder to break. Plus, you've got all that increased stabilization from your trunk. So just a quick, I don't know if we really need to go over this, but basically, you have a huge axial load on the top of your head. Okay, you dive into a pool or to a river, head goes to rock, or you get shot out of a car and lawn dart straight into the pavement. You're going to get a burst fracture of the atlas, what we call a Jefferson fracture, named after Dr. Jefferson, I'm supposing, not Thomas. And then the hangman fracture is when you get that sudden hyperextension like this. Either if you did something naughty in Malaysia and got hanged, the actual knot goes in front of the face, not back here like you see in the movies. I had a neurosurgeon back at Hartford who said he did a conference in Malaysia, and they said, oh, no, it goes right here because they still, I guess, hang a lot of people there. And then breaks here and here. What's that? Oh, jeez. Yeah, basically, kills you. And so, but the reason it matters for us is that if some knucklehead is driving along drunk out of their mind, forgot to put their seatbelt on, and decides to go straight into a tree, a lot of the times they're going to hit the windshield like this. With that type of injury, that can cause that hangman's fracture. So when these happen, especially around, because remember 40% of them are going to happen on C2. A lot of them happen actually here, what we call a type 1. That's actually pretty stable. The type 3 here through the body, you got the rest of this thing to kind of stabilize it. They're not too bad. But if you get it right at the base of that tooth, right at the base of the dens, those are the ones that are a little unstable, and you might end up buying yourself a halo. And again, this thing, you're in this vest. It's got those nice metal spikes, and it's got some screws that go straight into your skull to make sure you don't move it. You still have about 4% range of motion with the halo, okay? So let's remember that when we're putting people on backboards and C-collars, that it might not be quite as useful. And then you get down to thoracolumbar, which is a fancy way of saying basically everything else is not in the neck. One of the most common ones you're going to get is a chance fracture. Okay, so this is for the folks who are wearing their seatbelt. They've got the lap belt on, but they decided not to put the shoulder belt on. Bad car accident, you hyperextend forward, you end up compressing the body of the vertebrae here, and then ripping through the intraspinous ligament, and you end up with a bunch of gravel in your back. What you don't want to have happen is it punches through this posterior ligament, ends up pushing against your spinal cord. Bad things happen. So that's kind of an overview of the type of injuries you can get of the spine. So I'm going to go through a little bit of history here, just kind of a little bit of background. So back in 1949, after all the stuff that they saw in World War II, because I think Korea started in 1950, the American College of Surgeons, those are all the surgeons in the United States, decided to develop the Committee on Trauma and to figure out how can we start applying the lessons that we learned in World War II to what's now starting to happen a lot more frequently in the United States, particularly when more and more people are getting cars. This is right before the development of the interstate system that Eisenhower brought back from Germany, which led to a lot more car wrecks. And then in '61, Dr. R. Adams Cowley created the first trauma unit at the University of Maryland. How many of you heard of shock trauma? Okay, so this is in Baltimore. Two, soon to be three of the people I work with at the hospital I'm at in Silverton trained there at Baltimore. And it's the first, and it's actually probably the best trauma hospital on the planet. Because especially when you listen to one of them, you've got like the level 4s. I work at a level 4. Then you got the 3s. Then you got the 2s, like Salem, Ben, that type of thing. Then you've got the 1s and kind of that rarefied atmosphere. That'd be like Emmanuel and OHSU. These are the big academic centers. And then you got Intergalactic, and that's shock trauma. Okay, it's a 7-story hospital that only does trauma, and the only way you can get into that place is either landing a helicopter on the roof or coming in via an ambulance. And then they bring you up to the 2nd floor, which is they call the trauma receiving unit, or the TRU. It literally looks like a NASA control center with all the desks lined up and everything like that. And then this huge U shape around, it's all filled full of trauma patients. It's insane. Plus they wear these pink scrubs. They originally did that because they wanted to save money and nobody wanted to wear pink scrubs. Now they've got a serious problem because anybody who rotates in shock trauma steals the scrubs to prove that they were in shock trauma. And then in 1973, Maryland created the first statewide trauma system. They also do it in conjunction with the Maryland State Police, who actually own the helicopters and then fly everybody in. So Dr. J.D. Farrington out of Wisconsin, I believe, wrote a seminal paper in 1966 called Death in a Ditch, and you can access it, okay, if you want. And it's one of the very first descriptions in the medical literature of how we take care of trauma-free hospitals. And again, they didn't really have a whole lot of data to go off of. They were kind of making things up as they went along, which you can understand. They were taking the lessons learned from both World War II and Korea, and then other things they had seen to try to figure out, okay, how do we prevent things from getting worse? And so that's where they started developing backboards, tying ropes to them. That doesn't make that pleasant. And then actually using ropes to extricate people out onto the backboard. Now, things have changed, but I don't want you to think too ill of them because they were kind of making this up as they went along. They did a pretty darn good job. And then there was ATLS. So in 1976, Dr. James Steiner was an orthopedic surgeon, and he was actually flying his plane and then accidentally crashed in a Nebraska cornfield. His wife was killed instantly, and 3 of his 4 children, along with Dr. Steiner, were actually severely injured. His 4th kid only had minor injuries. And then the care that he received in the local hospital was very substandard. And he said, quote, "When I can provide better care in the field with limited resources than what my children and I received at a primary care facility, there's something wrong with the system, and the system has to be changed." That's what created ATLS, Advanced Trauma Life Support. This is what all the surgeons take, most ER docs, if they're not already board certified in emergency medicine. It's extremely important. The farther away you live from, areas that have a level 1 or level 2, the physicians really need to know this. PHTLS is a derivative of this, okay? It's basically everything that we can do in the pre-hospital environment as opposed to in the hospital. There's actually not a whole lot more I can do in the ED that you can. I can crack a chest if I got to open up the pericardium, okay, if somebody's got a tamponade. I can clamp the aorta if I need to, but I don't have a surgeon where I am to be able to take care of that, so I don't do that. And I can give blood. There's not a whole lot else I can do for trauma. Bad trauma doesn't need you. It doesn't need me. It needs a surgeon, okay? And so that's why ATLS and PHTLS are very similar. Because again, me as an emergency medicine doc, there's not a whole lot more I can do. Okay, so I'm not saying that to make you think that what you do doesn't matter. What you do absolutely does matter. What I'm saying is that basically there's not a whole lot more I can do, okay, than really give blood. And once you start getting blood or even better whole blood out in the field, your care is going to go up even more, and you're going to be able to give those patients that definitive care, those level 2s and those level 1s. 4s and 3s really only kind of stabilize. So spinal immobilization versus spinal motion restriction. You're going to start hearing some new language out there of spinal motion restriction because we've realized spinal immobilization is a misnomer because you're not immobilized in squat. And so let's actually try to just simply restrict the movement rather than trying to rigidly immobilize it because we know that that's not possible. Like I showed you earlier in that halo, okay, you're still getting 4% of movement. You're still not completely immobilized. So in 2018, there was a position paper by NAEMSP. These are all the EMS physicians. And they got together with the trauma surgeons and then the emergency medicine physicians. And one of the points they made in this position paper was, I quote, end quote, "While backboards have historically been used to attempt spinal immobilization, spinal motion restriction, or SMR, can be achieved by use of a scoop stretcher, a vacuum splint, ambulance cot, or some other similar device to which a patient is safely secured." Okay, So we don't need to be using these. This is the national organization who's saying there's other alternatives. And I'm going to show you why I think the other ones are probably a little bit better than strapping people to, you know, a chunk of wood or a stiff piece of plastic. So first off, I want to go through penetrating trauma. Don't use unpenetrating trauma, okay? Back in 2010, a bunch of trauma surgeons wanted to see, okay, what happens if we start putting C-collars on people who get shot? And what they found is by going through all those charts, you were twice as likely to die if you were put in a C-collar and immobilized if you had penetrating trauma, shot or stabbed, versus if you didn't, okay? So if I have a group of, you know, 100 people, and they're all shot or stabbed, and I immobilize half of them in full spinal immobilization, and the other ones I just stick on a cot, I'm going to get twice the amount of death in the ones that I tied down to a long backboard. Okay. And they also went through, and there's something called the Injury Severity Score, the ISS, that they use to kind of normalize everything. So that way you're comparing apples to apples. And again, they found that in penetrating trauma, you actually made things worse. Newer data actually shows that there's something called the number needed to harm, all right? And that if you've got 10 patients with penetrating trauma and you put a C-collar on all 10 of them, you're going to kill one of them. That's what they mean by the number needed to harm. Everybody talks about aspirin and chest pain. The number needed to treat, which is you give somebody a treatment and it actually saves their life, okay? The number needed to treat all those patients who are having a STEMI, okay, not just chest pain, but an actual STEMI with aspirin, is 1 in 42. And people go bonkers, like, you didn't get the aspirin on board. And so that's what I'm trying to show you is that in penetrating trauma, if you put a C-collar on them, you've got about a 1 in 10 chance of killing the patient. So any penetrating trauma, do not immobilize them. Do not put a collar on them, okay? Because the initial trauma has already been done. If they get shot, and there's another study done in 2009, 91% of the patients were male, go figure, that the damage was already done, and that any attempt to immobilize is just going to make things worse, okay? And that's one thing to really remember is that when you go on a trauma patient, blunt or penetrating, and they've got any type of neurological deficit, that damage has already happened. That damage happened when they fell off the roof, when they got shot out of the car, when they, you know, right before whatever happened said, hold my beer. That damage happened. You're not going to make it worse unless you are actively twisting the patient's head like a chiropractor. You're not going to make it worse, okay? So just be gentle, don't be cavalier, but just realize that putting people on these backboards aren't going to do it. And for the NAEMSP position paper, there is no role for spinal motion restriction in penetrating trauma. That emphasis is theirs, not mine, okay? So this is where most of you are going to want to shoot me in the face. Because there's a little bit of math, a little bit of physics, okay? So we all remember from high school physics, kinetic energy is equal to 1/2 the mass times the velocity squared. I did some math, and hopefully it's right, on the back of a, you know, notepad a little bit earlier. And I figured out that a fully loaded dump truck, which is about 30,000 pounds, going at 25 miles per hour, has less kinetic energy when it hits something than my mini countrymen parked out there with going 75 miles per hour, which is the normal speed basically out here on it. Okay, so just remember that. My little mini out there, if it hits you at 75 or hits anything at 75 miles per hour, is going to have more energy that's going to get transferred to something else or to the person driving it than a fully loaded dump truck going 25 miles per hour. Okay, I know that sounds counterintuitive, but it's this velocity squared thing that makes all the difference, okay? Firefighters also know this intuitively when they're putting water on a fire from a hose, okay? Because they know that each size of that hose is going to be able to give them different gallons per minute for the dead French guy law, which I can never remember his name. It's Poisson, but it's basically fluid through a pipe is inversely relational to radius to the 4th power. Same with IVs, okay? Because basic physics. So firefighters know this very, very well. There was another paper that was done in 1998. There's a link to it here. looking at trauma patients in Malaysia versus Albuquerque, New Mexico. The hospital that they were staying in Malaysia was pretty much at the same level of Albuquerque, same level of training for all the docs, same number of surgeons, residents, everything else. The only major difference is they didn't have at the time an EMS system. Somebody got into a bad car accident, they threw them in the back of the truck, car, whatever they had, and drove them to the hospital. Okay, that's how they got there. Whereas in Albuquerque, if you were in that same exact accident, tie you to a backboard, bring you in. And what they found, looking at over 5 years of data, was that, and after they normalized everybody for that injury severity score, so they're looking apples to apples, is that the Malaysian patients did twice as better as the Albuquerque ones. So if you're in Albuquerque, you were twice as likely to have an injury that would actually get worse by getting tied to a backboard. Okay, and they also found that, that there's, after they ran all the numbers, there was a less than 2% chance that immobilization had any type of benefit whatsoever. But it also looked like it had a higher incidence of harm. Okay. So here's a bunch of other reasons why I don't like it. Theoretical benefit. There has never been any proven benefit to lung backboards in the literature. Period. End of story. Now, when you look at scientific evidence, especially for medicine, there's something called the randomized control trial. It's basically the gold standard. You take one group of patients and you do one thing to them, the other one you do something else, and you make sure that just random people get put into either bucket. Okay, so that way you're always comparing apples to apples. And the randomized control trial of doing basically nothing versus full immobilization has never happened. That's probably not going to happen in the United States because of lawyers, right? Because somebody's going to get sued over that. So I'm hoping that it'll eventually happen in some other country that we can then translate to the United States and determine once and for all, do these things actually work? Okay, but all the evidence is showing that they do not. When you are tied down to one of these things, you are going to have an increase in pain. Okay, we've known that since 95 or above. You're going to get ulcers. Okay, what usually happens is granny gets tied to a long backboard because she had a ground level fall. I'll tell you later on why you should never do that. And then ends up waiting in either the waiting room or a hallway bed because all our hospitals are overloaded and the physician hasn't had time to go evaluate grandma, and she's been tied to this thing for 2 to 3 hours before you can finally get her off of it. During that time, she's going to develop ulcers possibly on the back of her head, buttocks, shoulder blades, back of her heels, any hard point that's pushing up against that board, because again, you spider strapped down to that. You're going to get increased intracranial pressure. All right. If you've already got a bad trauma patient and you're worried about bleeding in their head, one of the last things you want to do is try to jack that pressure up even more than it already is, because you can cause an increase in that herniation, which is going to kill the patient. More of a pain in the neck to manage their airway. Again, they're tied to that board. It's not going to be as easy to get in there and get that airway intact. Decreased pulmonary function in healthy non-smokers. That means that you're going to have a much, much harder time taking a deep breath. And that's in healthy volunteers that don't smoke, okay? And so patients are going to feel like they can't breathe. It's because they can't, because they're tied down to this thing. They also lead to unnecessary scans because it's hard to distinguish what pain is from the actual injury versus what it is getting tied to that board. And so this is going to lead to more radiation exposure, and it's going to take longer to get the patient through, and it's going to give them an increased cost for stuff they didn't need, okay? Particularly with kids. Personally, I try not to light up a kid unless I absolutely have to. They're little, okay? They're still growing. They don't need a bunch of x-rays messing with their DNA. Movement. So there was a study done out of, what was it, San Antonio and Fort Sam Houston by San Antonio Fire using healthy volunteers. They were 2/3 were female. Average age was 46. Mean BMI was 31. Okay, so a little bit on the fluffier side. And what they did then is they either just put them on the stretcher, or they tied them to a long backboard, and then they put a bunch of measurement devices on there and measured them with lasers to see how much they actually moved. And what they found, and again, they were driving them around, just want to make sure, yeah, they were driving them around in a parking lot, 30 different turns, 20 start and stops, and they did not go any faster than 20 miles per hour. When's the last time you had a patient and you were going less than 20 miles? Okay. What they found is that head movement was about half on the stretchers what it was on the long backboard. So you're actually going to move around less on the stretcher than the backboard. Chest movement, less on the stretcher than on the long backboard. Hip movement, less on the stretcher than on the backboard. And they found that also that the fluffier the patient, the more movement that you had. Okay? Again, healthy volunteers, but a proof of concept paper. And they were going relatively slow. I think the more interesting one was if they put a EMT student driving that thing and made them a little bit amped up, got the old RPMs going, and see how much they move around then. But you wouldn't be able to get that past the institutional review board because they'd be like, that's not safe. And you're like, well, yeah. Spider straps. Yeah, spider straps. I believe they were supine, but they've also done studies showing that there's not much movement if you do keep them bent at the hips. So that way, if you keep them bent at the hips, again, spine ends here, starts here. So if you keep that entire thing, no, I'm not doing a very good job, but if you keep that all in line, it's not much of a problem. Because if you got a patient who's laying flat and they feel like they can't breathe, fine, sit them up. Just make sure that from here to here is all still in line. What's that? Bending in the right spot, exactly. So there was a study done out of Spain and another one done out of Thailand that looked at how much movement do you get when you strap somebody to a long backboard, how much movement do you get if you put them on a scoop stretcher. Didn't really notice much of a difference. The data was pointing more towards a scoop stretch. I'm having a stroke. A scoop stretcher would be ideal. One, it's easier to get them on and off of, and two, there was actually a little bit less movement with that on both of those. And then here's another one looking at that they did out of Scandinavia, where they were having healthy volunteers extricate themselves from a vehicle either with or without instructions. Every single one of these volunteers had no knowledge of EMS whatsoever. Okay, they didn't know how to get extricated, so they didn't know what was going on, which is the way you wanted this particular experiment. Excuse me. And what they did is 4 different ones is they had the patient get out with instructions with no collar. So the patient's sitting there and you're like, put your left foot outside the car, put your left hand over here, now turn. So they're talking the patient through how to do it. So one of them they did with instructions but no collar, another one with instructions with a collar, no instructions, no collar, and no instructions with a collar. And what they found is that, fortunately you can't see it as well up there, all these dark areas, okay, is where they had clinically significant less movement, which is what you want. And what their hypothesis is that if you have somebody get out with no instructions whatsoever, it's actually better because the driver in that car knows their own vehicle better than you do suddenly arriving. So they know all the small little micro movements to make to get out of their own vehicle. And so that maybe ideally when we try to extricate somebody from the car, if they're awake and with it and are able to stand, have them get out of the car on their own. Put a collar on them if you're worried about it. Just tell them, I need you to get out of the car. Take it easy, take it slow, but don't think that we know better than they do in terms of extricating from their own vehicle. Again, there's links to all these in there. There's another study done out of Manitoba. So you remember how I was complaining about how there's never that randomized control trial? This was the start of one. They got 9 whole patients. They don't really describe in the paper why they decided to cut it off early, but they got 9 whole patients. So there's not a whole lot of information you can get from this because they had 9 whole patients. But what they found is that if the patient was not compliant, there was a lot more movement, go figure. but that you again had, there wasn't really much movement between caller only and board plus caller, but they left out a lot of the critical details. So again, it's just kind of one of those papers that makes you say, not really one like, oh, this is a slam dunk, unfortunately. So I really, really wish they would have gone farther with this one and explained why they couldn't, to kind of give other people an idea for studying this. So usefulness. This is that one we were talking about earlier from Malaysia, comparing that with Albuquerque Ambulance. And then Brian Clemency, I think he was out of Buffalo at the time, looked at little old people who fall down, go boom, and found that none of the patients, make sure I get the numbers right, found that only 0.5% of all patients on a long backboard had an unstable injury requiring surgery, and that none of those were ground level falls. So grandma or grandpa falls down, okay, and they're just like, oh, my back. Don't tie them to a long backboard. Okay. The data shows us that don't. For ground level fall, don't worry about it. The other thing too is don't do the standing takedown where you stand the patient up, stick the backboard behind them, and take them down. There's no reason to do that. They're already standing. Have them walk over the gurney, sit down on the gurney, and lay down. Okay, standing takedowns are a thing in the past. And then there was another study done in 2020 where they looked at kind of a before and after, kind of a natural experiment, when they got rid of the existing spinal mobilization protocols for tying people to backboards, and then looked at it afterwards where they just did a simple spinal restriction where they had them on the cot. There was no change in the injury rates. When I was back in Connecticut, we did this during my fellowship statewide, and we never noticed a difference in injury patterns whatsoever, other than patients seemed to be a little bit more comfortable, and some of the ER docs got really bent out of shape. So did the trauma surgeons when we brought them in. And as one of my program directors said, well, Jesse, this is an opportunity to provide education. Okay? So that's one of the reasons I want you to have these references, so that if you do get a physician or nurse who bites your head off, because again, you have to go by your localized protocols. Don't just go out, well, Jesse said, because somebody's going to be like, well, is that idiot your medical director? Be able, if you're following your protocols and you're like, we got rid of this, and somebody's still chewing you out, this is all the data. Show them, no, we're probably doing harm to our patients by sticking them on these things. So questions on long backboards, so we're going to skip the C callers. Yes. So that's an excellent question. If you want to use a long backboard as an extrication device or like a Stokes stretcher, whatever, because that's what you have, then absolutely. If you're going to use a backboard as an extrication device, I don't mind. But I would try to get them off of that as soon as you can, because the cot's going to be way more comfortable and less likely to cause other problems. But again, I should have said that earlier. It's an excellent point. You can use a long backboard as an extrication device. I'm not trying to say don't. But don't think for a second that's really going to cause much immobilization. So. Not to my knowledge. I do remember seeing something somewhere kind of vaguely touching on that, but as far as I know, they've never really done a trial looking at one strapping mechanism versus the other. But I'm trying to think of it, and I can't really think of how that would really improve mobilization, just in terms of how much you move on these things. Honestly, I think the best way to do that would be find something that is really, really hard to move on, because again, it's either that smooth wood or that smooth plastic that the patient's. I still wouldn't buy it. I'd be like, put them on the lasers, or some other type of it, so you can actually get data as to how much they've been moving. because I mean we've all seen the picture of the EMT student that got taped to the ceiling, and so you know, duct tape might be the best way to do that, but it's a little bit more difficult to get it off. They do. Oh, sorry. The question was if there's a difference between different types of strapping mechanisms, either cross straps or spider straps, correct? Other questions? Yeah. So the question is whether or not there is a study looking at vacuum versus long backboard. I believe I did see one, and you got a little bit, you got better immobilization with that, but they weren't. They were looking more at movements and not so much adverse effects. So the question was, yeah. So the question was if a vacuum splint worked better or had fewer negative side effects than the long backboard. I don't know the question or the answer to that one in terms of the different studies that are out there. It's an interesting point. My thing would be, is a vacuum splint going to be better than putting them on a cot? But the other thing too is so one of the other notions in this is that the injury has already happened, and so the concern we always have is, are we going to make the injury worse? Now, if you look at, for example, let's say I get a C-spine injury, it takes about 2,000 to 6,000 newtons of force to cause a C-spine injury. If I lay down on this table and I hang my head off the back of this and just basically let it go like that, that's only 40 newtons, okay? Because you're looking at a 4-kilogram head, and then gravity is 9.8 meters per second squared, or 10 meters per second squared. And so that's only 40 newtons. So you're looking at, you know, possibly up to 100 times more force that you would need than me just basically letting go of my head like that. Or if you're moving somebody and their head accidentally went like that, you would cause additional damage to that because you haven't put more energy into the system. And so that's why I think the whole notion of spinal immobilization really gets overblown, or spinal motion restriction gets a little bit overblown, because again, as long as we're being careful and not tweaking people really hard, the likelihood that we're going to put even more energy into the system to make an existing injury worse or cause one is insanely low. It's insanely low because again, the damage unfortunately is already happened. When I was a medic, one of my coworkers had a patient. Anybody ever been to Silver Falls State Park? Yeah, so there's a lot of steep cliffs, and a lot of people will like to go over the barriers so they can get that perfect picture. And this lady went over the barrier and fell 80 feet, was somehow still alive at the bottom. She had to have her airway managed. And then when they got to the receiving hospital, the trauma surgeon chewed my partner out because he said, when you gave her that paralytics, it relaxed all the tension in her neck, and that's what caused her C-spine to be, her cervical spine to be severed, the actual cord. And he really took it personally, and I was like, no, that's bullshit. And this trauma surgeon then, you know, was being an a-hole to probably the best paramedic I've ever met, and was feeding him false information because that trauma surgeon didn't understand basic physics, which is frustrating. Other questions? Yeah. So the question was, if somebody had penetrating trauma and the existing object was still impaled in the spinal column, would you change anything? I would not, because again, the damage has already been done. Now, if you got a piece of rebar sticking out of somebody, then try not to yank it too much, because with that lever, you get that moment arm, and that could possibly make things worse. But if somebody got shot or stabbed, damage is already done. Other questions? These are fantastic, by the way. Okay, let me talk about C-collars for a wee bit. So during Vietnam, C-spine precautions were taken with sandbags and tape for blunt trauma. And the early estimates were that about 25% of all C-spine trauma actually resulted from improper immobilization post-injury, which meant the poor soldier was fine and then got tied to this board improperly, and then it probably made things worse. Okay, about 25% of the time. Which, if you're a soldier serving your country, you really don't want to have that happen. Okay. And then they did another study in 2011. Okay, where what they did is they had an orthopedic spine surgeon. So this is a physician that all they do is spine stuff, and they created a instability and had a neurosurgeon come in, create an instability at C5, between C5 and C6, because that's the most common spot you're going to get a C-spine fracture. And then had some electromagnetic motion capture devices placed in there, both above and below where the instability was created. And then they had the orthopedic surgeon then come in and apply either your typical C-collar, the one piece that we've got, or the fancy like two-piece Miami J, Aspen, whatever they are now, and found that there was no, and then they also compared that to manual inline stabilization without a collar and basically moving the patient over to the gurney. There was no difference in movements of those three different modalities of moving the patient. They also only lightly embalmed the cadavers so that you would get a little bit more movement. But just remember that if it happened in a patient who actually had a busted bone in their neck, they're going to have a way more muscle tone, okay? Because you're going to get bleeding, inflammation, everything's going to lock up, and they're kind of already immobilized then right there. If you ever broken a bone, you know how much it hurts. It's not going to want to move. So plus you're going to get bleeding, swelling, everything else. So it's actually not that easy to move it around. So they didn't find, in that particular study, they didn't really find any harm with putting those collars on, but they didn't find a benefit either. And these things were integrated into ALTLS without much evidence. So there was a study done in 2003, the esteemed New England Journal of Medicine. And what they found, what they were looking at is they were looking at two different, what we call clinical decision rules that we use in the emergency department to determine, okay, do you need to have a scan of your neck or not? And there's one called the Nexus, which I don't like, and there's one called the Canadian C-spine rule, which I really like. And this study found that the Canadian one actually works better, that misses fewer injuries, and there's fewer scans. And you don't have to worry about midline tenderness, because everybody and their mother, if they look at a bad car wreck, they get midline tenderness, it seems like. But what they did is they enrolled over 8,000 patients over this period. One of the things they figured out from this is that only 2% of all traumatic neck pain has a clinically important injury. Okay, so only about 1 out of every 50 patients with neck pain that's involved with trauma actually has a significant injury, which is one that essentially like you're worried about something pushing on the board. So the other thing too is rarely do we pad things right. Back in '98, they had a bunch of test subjects. Had the C-collar put on, put them on a backboard, and then they're trying to measure, okay, are you in extension or are you in a neutral position? And they found with women that they needed about 1 1/3 inches behind the head to get them neutral, and in men, on average, they need about 1 2/3 padding to get them neutral. And those little head beds that you've got on there are not that thick. Okay, so even with the head bed, you probably got the patient in extension. And then there was a systematic review that they did in 2022, a bunch of British doctors, excuse me, and they found that there was only really 9 studies that really looked at how well C-collars actually immobilize people. 6 of the studies said that they should not be used in pre-hospital trauma patients because there's more likelihood of harm than benefit. And 3 of the studies actually said, we don't know. There was not a single one that showed any type of benefit. Right? And then they did another one. Sorry, grandma's dead. With cadavers, where they went in and they actually induced an instability right between C1 and C2. Remember we were talking about, which is way up there. If you get a break up there, you take out the phrenic nerve and you can't breathe it. Okay, bad things happen. And then they put a C collar on, and they found that the average amount of what we call distraction, which is moving, okay, C2 and C1 away from each other, was about 7.3 millimeters. Okay, so you're putting that collar on, and you're actually stretching out the neck. And that's with the no neck. Because the other thing, too, is that we all have those C-spine bags. We've got 4 different sizes of collars in them, plus the pediatric ones. How many of you have ever actually used a properly sized ball? Everybody grabs the no neck, all right? I know I did, because when I first, was a paramedic intern, I was like, oh, well, we got to properly size this, and my preceptor just kind of looked at me like, and so everybody uses them. So I'm not trying to be all doom and gloom. There is a couple of interesting things. Is something, again, Canadian C-spine rule I was talking about. And a guy named Ian Steele at the University of Ottawa up in Canada published this back in 2001. And what they found is that they markedly decreased the number of scans the patients were getting based on this rule. I'll show you it in the next slide. Then he was like, hey, maybe paramedics can do this. So they did it back in 2009. And what they found is that the paramedics are actually more cautious than the physicians. And I think in the original one, there might have been 1 or 2 that were missed. Paramedics didn't miss a single one. Okay, the paramedics were actually more attuned to the patient than the docs, maybe a little bit less cavalier, but the paramedics didn't miss a single injury. And then they did what's called an impact study. So right up there, okay, the first one, think about it as like making a recipe, okay? I made the recipe, that would be one of the preliminary ones. Now I'm going to see how the recipe tastes, okay? Does it work? Yes. And then, then it actually works. And then with the validation one for paramedics, he's like, I can make a slightly different type of cake, and it's still going to work. The impact study is, how does the cake actually taste? Okay, it actually tastes pretty good, and it works, and it was done in an outside environment. So anytime you've got something that's been validated multiple times and then has what we call a positive impact study, you're good to go, right? So again, don't do this unless your medical director is signed off on it. But basically what the C-spine rule does is any type of high risk factor. So if they're over 65, you can't use it. That's why a lot of times you just get scanned to grandma and grandpa's head and neck. They're notorious for breaking stuff because they're all osteoporotic. Was there a dangerous mechanism? And the dangerous mechanism is, again, let me open this up a little bit more for you. Did they fall more than 3 feet? Okay, or down 5 stairs? And this isn't like I am about 5'9". Did I fall down and hit my head, even though my head is 3 feet off the ground, just at baseline? That would be like if I'm standing up here and I decide to lawn dart down there, that would be dangerous injury. Was there an axial load? Did you dive into something and smack your head against the bottom of the pool? Were you in a motor vehicle crash at high speed, which they're Canadian, so it means measuring kilometers per hour, but basically translates to over 60 miles an hour. Was there a rollover? Was there marked intrusion into the vehicle? And then were you a bicyclist struck or a pedestrian? And what they found, and then or do you have any paresthesias in the extremities? Okay, that's like, yeah, I got some really bad numbness stinging going down my arm or my leg, or I can't move my arm or leg. Okay, you're done. We got to get a scan to make sure you didn't injure before. So you answered no to all of those. Any one of these that is present, not all of them. All you need is just one of them, and you're good to go on this one. Was it a simple rear-ended motor vehicle crash? Okay, this is not getting hit behind from by a bus or a dump truck and get shoved into traffic. Okay, that's not a simple rear end. This is like the Geico check. Okay. Are they in a sitting position in the emergency department? Would they self-extricate? They're able to ambulate. Okay, if they got hit by a dump truck, but they're walking around on scene, boom, you're good to go. Delayed onset of neck pain. Okay, this is like I was in a motor vehicle crash, like 3 hours ago, and now my neck's starting to hurt. That's delayed onset. And then absence of midline C-spine tenderness. Okay, so again, any one of these things, not all five, but any one of them, boom, you go down to the next one. Can you rotate more than 45 degrees off midline? Yes. You don't need a scan, which also means you don't need a collar. So, but again, only do it if your medical director has validated it. They're also looking at this for kids as well, so we can decrease the amount of stuff that we do on kids. And what they found is it has something called a negative predictive value of 99.8%, which is amazing, which means 0.2% of the time the rule is going to be wrong. For a clinical decision rule that we use in medicine, that's phenomenal. Okay. And then if you really want to get into the nerd in the sense of the specificity for this particular test. By the way, anybody know the most accurate test in medicine? The what? Poke test? I love it. I love it. So the question was, the poke test is the most accurate. I love it. Okay, so the second most accurate test in medicine. Anybody know what it is? Urine pregnancy. Okay, because if you pop positive, you're pregnant. If you pop negative, you're not pregnant. It's really hard to confuse the two. But yeah, it's actually the most specific and sensitive test in medicine. I'm going to steal that, by the way. So this is kind of the algorithm that you go through for kids. Again, if your medical director is okay with it, and then there's no great data really to support long backboards at all. C-collars, maybe. It's just really still not there. But me personally, I don't blow a gasket if a medic brings in a patient without a C-spine, without a collar, or without a long. And I kind of do blow a gasket if they're still tied to a backboard. I'm like, what's your medical director doing? This doesn't make any sense. Usual care is kind of based off of BS. But the biggest thing is we need better data. Question. So the question was using sorry, I'm doing this for the folks at home. Using like a rolled up towel or something to create a bronch collar that's a little bit softer. I still don't think it's going to do a whole lot. And you also have to be worried about the thickness behind the neck if you start putting them into C-spine extension like this, because you've got a roll behind there. But it certainly sounds more comfortable. It certainly sounds more comfortable. Other questions? Yes. Yeah. So I use this all the time in the emergency department, and so one of the first things I do is that obviously if they're over. So sorry, the question was moving the neck 45 degrees to the left and right makes them nervous. One, don't do this unless your medical director signed off. If you do have a progressive medical director and they signed off on it, awesome. But if they're over 65, I can't use this in the emergency department. It's like, Granny, you're getting scanned. Okay, I'm going to introduce you to the magic white donut that can tell us everything we need to know. Next one is, I asked them to describe the accident. Okay, vast majority of the time, I'm like, yeah, that's low energy. And then I got to spend all this time explaining to the patient why I'm not as worried as they are, because you still want them to feel validated. So when something really bad happens, they actually come back. And then I'm like, okay, any numbness or tingling in your arms or your legs, have them do jazz hands, all this other stuff. And then I'm able to go like, okay. Then usually from talking about everything else and the fact that they walked into the emergency department, okay, they're already ambulatory, so boom, I can go to the next one. But let's say they came in by EMS, then I can kind of go through these and see if any of those fit. If they don't, like if I say no to all of these, then I got to go over here and I got to scan. But if I get a yes on any one of these, then I'm like, okay, move your neck to the left, Move your neck to the right. Sweet. Good to go. And if you've never done it before, because I remember when I was an intern, and that's when I learned about this when I was in residency, I was like, are you kidding me? And my attending, that's the supervising doctor, is just like, you'll be okay. And I was like, okay. And yeah, so, but again, you have to meet all of these conditions, all of these. The other thing too is there's also exclusion criteria. So if they have a GCS less than 15, you can't use this. Yeah. If they've got unstable vital signs, if they're less than 16 years old, there's a couple of other things that if they don't meet these criteria as well, which are kind of blurry, unfortunately, then I can't use any of this. And then I have to start using clinical judgment. Okay, am I going to throw them in the CT scan? With kids, it's actually really easy because usually as soon as I walk in, the kid looks at me like this. And I'm like, oh, that's awesome. And then I kind of walk around to the other side of the kid. And then the kid does one of these things. And I'm like, we're done. Uh-oh. Oh, question online. Yeah.
A patient is supine on the floor, but you use a long backboard to get them on the stretcher to take them.
If all you have is a long backboard to get them off of the floor, then yeah. The other thing is if you've got a scoop stretcher, which most ambulances do, I would just scoop them, put them on the gurney, and then pop the scoop stretcher off because it's going to be way more comfortable. Question? Yes, I apologize. Yes, so the question was, is the patient doing the movement or am I doing the movement? The patient's doing the movement. I'm not doing this to him. So, because if the patient can't do it and I decide to do it, I can make this decision. And so, excellent clarification. Tacos. Thanks, folks. Thank you, sir.